So I'm pleased to welcome everyone back to our concluding panel for this workshop. As I introduced myself yesterday, I'm Brenda Nevijan. I'm a member of the forum representing the Oncology Nursing Society, which is a member of the forum. And our last session of the workshop is going to be on the gaps in quality care and models of care. And yesterday and already this morning, we've heard referencing to gaps a number of times and in a number of ways. And so this panel is going to be discussing a variety of those gaps. You do have their detailed bios in your handout. They will be presenting one after another. But Dr. Freyer, who will be first, is presenting on transitions and gaps in AYA survivorship care. Following him will be Dr. Baker on palliative and end-of-life care for AYA patients. Then Dr. Hudson will report on gaps in the evidence base and research priorities for AYA survivorship. And last will be Dr. Park, who actually is going to be combining the last two presentations. Dr. Patel was unexpectedly on Friday notified that she needed to be on the Hill today, this morning, in fact, at 10 a.m., and so is unable to be with us. But Dr. Park graciously agreed to reinsert some of the work that she's done on with ACA and worked with Kavita to be able to present both the insurance challenges faced by AYA as well as a look at the Affordable Care Act. And we appreciate that happening. And then we'll open up as we have for discussion. So, Dr. Freyer, welcome to the podium.
Okay, hopefully I can figure out how to use the mouse here. Good morning, and thanks to the IOM for presenting this really enriching conference, for the invitation to speak here, and also for all of you persisting until the end. I'd like to begin by acknowledging the many people who have been part of the work that I've had a privilege to be part of. I think perhaps more in AYA than many other disciplines, it really does take a village. So just for a moment to acknowledge those individuals as well as many who are not able to be here. So over the course of the next few minutes, what I'd like to do is to cover a few points. First is to discuss exactly who the AYA survivorship population is. Second, talk about some of the needs of AYA survivors. Third, present what I feel is in some ways the central challenge of AYA survivorship. Discuss then the focus of this talk, which is healthcare transition and survivorship. Then segue to some of the barriers to successful survivorship transition, and then finally addressing the barriers so that we can move more into an action mode. So first of all, who are the AYA survivors? By age, of course, we know that the NCI definition for AYA oncology is 15 to 39 years. And I would argue that this age group is very appropriate to apply to survivorship because age really does continue to drive many survivorship issues. For example, the developmental biology or physiology of the host leads to certain characteristic types of late effects, for example, avascular necrosis, which we know is associated with teenage females. And secondly, some late effects emerge only or principally during this time frame. So infertility would be a good example of that, and the second malignant and subsequent malignant neoplasms that we've heard discussed already. In addition, there are a number of psychosocial challenges that are characteristic of this age group that include the backdrop of normal maturation into young adulthood. Just as we heard yesterday, this profoundly influences the cancer experience, and it does continue to influence the survivorship experience. And this can spin off, of course, into problems with having appropriate access to survivorship care, just like the upfront medical care, and of course adherence to medical recommendations for survivorship care. Another way of looking at the question of who are the AYA survivors is to consider the question that was hinted at yesterday, which is that we can talk about AYA survivors of cancer or we can talk about survivors of AYA cancer. It's a slightly different population, with the former being larger. And for purposes of this discussion, at least, this will be the focus, which are AYA survivors. So this is inclusive of the population of patients who were survivors of childhood cancer, namely those treated less than 15 years of age, survivors of adolescent cancer, somewhat arbitrarily defined as 15 to 19 years of age, and then survivors of young adult cancer, which would constitute the rest of the AYA spectrum. And as I'll discuss a little bit later, this does have some potential implications for appropriate service models for this population. So what are some of the key issues that face young adult survivors? Well, clearly, detection and management of late effects is high on the list. This would include continued management of certain late effects or health conditions that have developed if they're present at the time of transition, as well as continued risk-based surveillance and preventative practices. And one of the things that makes the cancer survivor population different than other pediatric populations with chronic illnesses that begin in childhood is that for many of our patients, it's the potential for health problems, not so much the established health problems, but the potential for health problems that requires continued monitoring and presents us with an opportunity for prevention. Clearly, psychosocial functioning, which manifests in interpersonal relationships, including sexuality as opposed to infertility, which are different issues. And the 25 or 30% or so of our population that has been shown in behavioral studies to suffer from issues like chronic anxiety and depression. Health-related education is key. There have been studies performed by the CCSS and others that have documented serious lacks of knowledge, important knowledge that is health-related, that include things as basic as what the previous diagnosis was, as well as the elements of cancer treatment that they received, what their current state of health and health risks are, the disease prevention and wellness practices that we know we've been hearing a good deal about the last day and a half, about how those are so important. And then finally, financial challenges, which we know plague this age group as well, in obtaining and maintaining health insurance, and then seeking and finding employment that is appropriate and meaningful, but still relative to the disabilities that may influence what they are able to do. So with that as a backdrop, I would like to propose that the central challenge in AYA survivorship is the issue of suboptimal longitudinal follow-up. Now, this is fairly easy to measure, and I'm going to show results from 2 CCS studies that I think document this problem. One is simply by tracking clinical assessments that take place with providers, and the other is the extent to which risk-based monitoring for late effects is observed. But while it's relatively simple to measure, it has huge implications that reach into these various areas. First of all, if late effects are destined to develop in a particular individual, the lack of follow-up can lead to late diagnosis of those problems. And the flip side of that is that this is loaded with missed opportunities for risk modification and for secondary prevention of these problems. Clearly, there's a role for anticipatory guidance during this period of time. Many of these survivors really crave knowledge about, what their health risks are, what's likely to happen to them, what can they do to help themselves, and if they're not accessing that information by follow-up, they're missing out. And then finally and importantly, this really impairs our ability to do longitudinal research in this population, both for medical and for psychosocial and other outcomes. So what are the data that medical follow-up is a problem? Well, 2 CCSS reports I'd like to share with you. One was published a few years ago now, but remains very important, which shows that over time, measured by age at the time of the report in years in this survivorship follow-up population, plotted against the percent of survivors responding that they had had an assessment within the previous 2 years prior to being surveyed. And as you can see by the blue bars, the percentage of patients who over time at these different age groups have undergone a general examination, that would be with a primary care provider, is relatively good. The lowest it gets is about 65%. But when you begin to define the follow-up as being either cancer-related or even more so with the red bars of a cancer center visit, you can see that it begins at a low rate, only 30%, and then drops off to something that's abysmal, less than 20%. So this is clearly a problem that worsens over time. Another study from CCSS that was performed a few years later not only validated this and shows that at a median age of early 30s in this large population of survivors, fewer than 15% reported having a general survivorship assessment, and only about 17 or 18% underwent recommended risk-based monitoring. So when this same study then referred to the COG survivorship guidelines, which we know are evidence-informed and consensus-driven risk-based guidelines to provide clinicians with recommendations for monitoring based on treatment exposures, these investigators looked to see whether patients who were deemed to be at risk by virtue of their medical histories, to see whether they had actually adhered to the recommendations that are contained within the COG guidelines. So looking at a subpopulation of about 1,800 patients who were at risk because of anthracycline exposure, and whether they should have whether they actually underwent an echocardiogram in the previous 2 years, and then women who were at risk for breast cancer, whether they had undergone recommended mammography in the previous 2 years, only 28 and 40% of each of those populations respectively had done so. So follow-up remains a problem both in terms of returning for visits and also for undergoing risk-based monitoring. So one potential way to address this and to improve the long-term follow-up of survivors in the AYA age group is to emphasize a topic that is discussed widely in pediatric medicine in general now, which is healthcare transition. So what is healthcare transition? Based on a now classic definition from Dr. Bloom that's been published now many years ago, it's the planned movement of older adolescents and young adults from a child-centered to an adult-focused healthcare provider and environment. Pretty basic definition. Why is it important? Well, in the survivorship population, it's important in order to continue medically and developmentally appropriate risk-adapted monitoring, psychosocial support, health-related education that are relevant to cancer survivorship. We say medically and developmentally because in terms of the medical follow-up, there is risk-based monitoring that the general population may not be aware of, and in terms of the developmental appropriateness, many of our patients are treated at children's hospitals, and the follow-up of these adults should more appropriately probably take place in an adult setting with adult care providers who have that expertise. So the potential impact of healthcare transition in this population is that it could lead to the earlier diagnosis or reduction or prevention of late effects, to an improved health-related quality of life, and to perhaps enhance self-efficacy and general quality of life because these individuals are better informed. There's been a good deal published about healthcare transition in pediatric oncology, but many opportunities for additional data. There have been a number of published reviews that have made the case statement and provided conceptual frameworks for healthcare transition in this population, similar to those of other pediatric populations with chronic illnesses who age into young adulthood. And there have been discussions of general models of care. Some research and some data have been provided on topics such as the prevalence and types of adult-focused services that are available for childhood cancer survivors in young adulthood. There has been some description of current transitional care practices in a general sense through surveys of multi-center group institutions, for example. There has been some research and small studies done to assess what barriers and perceptions are important on a patient level, and similarly what sorts of perceptions on the provider level may influence the extent to which patients undergo healthcare transition. But where there is little data or no empiric data as of yet, although there are some studies in progress in this area, are outcomes with specific transitional care models. What are the determinants of transition readiness, and what are some interventions that can be helpful? And then finally, and related to this, what are the predictors of successful transition or interventions that may improve long-term follow-up? In terms of the potential barriers to transition, this summary here refers to a variety of impressions, perceptions, clinical experience, as well as some research data. But to summarize quickly, on the patient level, a number of the barriers relate to the fact that these patients often have complex medical histories and multiple risks, but in contrast, they may have a low personal priority for follow-up. Some of this, it's unclear what drives this, whether it just comes with the age group and the many activities that they're involved in and geographic mobility, or whether there's a role here of simply being unaware and not adequately educated. One barrier that's often explained is by these patients in focus groups and other small studies is that they don't really know who the new provider is going to be. They don't have a prior relationship with him, in contrast to the oncologist that they trust very much, and we heard that articulated very well in the patient panel yesterday. On the family level, what's been described is a sense of overprotectiveness of the parents who have often had a major role in navigating for these young people when they were in childhood. Now they're in young adulthood, and it's frankly difficult for some parents to let go of that role. And they themselves may have some level of emotional dependency on playing that role. And then similarly, there's the lack of a prior relationship with a new provider. On the provider level, clearly studies show that there's a lack of relevant knowledge and experience and comfort level with this patient population, if not a willingness to take care of these individuals. And there's some reluctance on the part of these primary care providers in particular to take on the care of these medically complicated patients who they don't know, and in the context of a very busy primary care practice may have difficulty accommodating. And then on the reverse, of course, is the fact that they don't have a prior relationship or sort of a pre-existing commitment to caring for this new individual. And then finally, on the healthcare system level, the loss of health insurance coverage, which we encounter regularly, at least in California, where our patients age out of the catastrophic health insurance at 21 years of age. They really run into a fiscal cliff of their own, and unless they are able to get insurance coverage through their parents, they're pretty much out of luck, unless they're lucky enough to be working at a place that provides benefits. A lack of seamless referral networks linking the treatment centers with providers, and then a serious lack of inclusion of survivorship in medical training. So as we approach the issue of how to address the barriers, having a model is useful. And this model that was developed by Lisa Schwartz and colleagues at the University of Pennsylvania is very useful. Clearly, there are a number of pre-existing objective factors that we can't change, but there is a big group of variables that are more subject to modification perhaps, and we have patient, provider, and parents included in that group. So it's this group of modifiable subjective variables that could well be targets for intervention. So that provides a segue into addressing the barriers. On the patient and family levels, in this publication by Schwartz and colleagues, what they demonstrate here is the patient being treated for the chronic health condition, this would be cancer in this case, with an outcome of engaging in medical care and transfer of care. There's this big period of a window of modifiability, if you will, in which we can increase transition readiness through developing interventions. And those application of targeted interventions is where we may be able to make our difference. On the provider level, clearly there's a need for additional medical training, both at the undergraduate level to introduce, at least conceptually, the issue of survivorship, and on a graduate level in pediatric and medical oncology fellowships, and also primary care residencies, opportunities to provide direct training experiences. And just briefly, at Children's Hospital Los Angeles and USC, we're now in our third year of requiring a rotation in cancer survivorship in the second and third years of our pediatric hem-onc fellowship. We just completed our first year of providing an elective to our pediatric residents so that they can get at least a taste of survivorship. And then finally, the primary care residencies at USC are next on our list. In terms of continuing education for the providers, There are papers like this that are being published on an increasing basis to acquaint them with the survivorship issues, as well as CME conferences. And then I think something that's probably underutilized are support systems for clinical guidance, which include efforts like this that was published in the Journal of Cancer Survivorship just last year in the Dutch experience, using a web-based support tool to support family doctors in the care, and also Passport for Care, which I'm sure many of you have heard of, which was developed at Baylor College of Medicine in conjunction with the Children's Oncology Group. On the healthcare system level, I'm focusing on models of care. And there are basically three models recognized. One where care continues within the cancer treatment center, another where care is transferred to a community-based provider, usually a primary care, and then a third model where it's a hybrid of the two. Now, clearly what's needed is more innovation with specific innovation with specific models and a comparison of the resource intensity and outcomes of those models. But it's clear as well that models don't work all by themselves. They don't run by themselves. There are many things that influence those, including the attitudes and preferences of both the patients and providers, where there needs to be an awareness, a knowledge on the part of the patients that they need this follow-up, and then motivation to pursue it. And then providers need to trust each other. We pediatric providers need to trust that our adult colleagues will be able to care for these patients appropriately, but there's also a converse acceptance of responsibility that's necessary. One subset of this sort of model is what's called tiered transitional care. The concept here is that the large group of survivors can be differentiated according to their long-term risk. In other words, that the type and intensity of required follow-up differs by group because some patients are more at risk than others. And this whole notion is implicit in the risk-adapted monitoring guidelines of the Children's Oncology Group. There's some experience with this in the United Kingdom, where Drs. Wallace and Iser have published validated classification for patients based on their treatment exposures, and those patients are followed in 3 different groups by either the specialized center, the primary care provider, or even virtually by mail. At Children's Hospital Los Angeles, we've developed a clinic for our adult survivors, and we use an adaptation of this where we have 2 risk levels. And on this busy slide, which just shows our clinical pathway, I really wanted to focus on this area here, which is that after being followed annually up until 20 years of age, the patients are then stratified into 2 groups and followed beyond 21 years of age for their long-term follow-up. The patients in group 1 who are at lower risk are those who have no radiation therapy and essentially low alkylators and low anthracyclines, whereas the patients who are in the higher risk group have had any degree of radiation as well as alkylators, anthracyclines in higher doses, and any stem cell transplant. So the patients who are in the higher risk group are followed rather than by their primary care provider. They're followed in our life clinic for adult survivors, where we feel that their situation requires and justifies the resource intensity that's needed for that group. We've been now conducting this in a pilot experience, completing our 3rd year in collaboration with a community-based primary care, community-based cancer center. This is leading to a planned approach that we are hoping to undertake in the near future at our academic affiliate, the USC Norris Comprehensive Cancer Center. And what we're envisioning is having 3 streams of survivors, the 3 that I mentioned earlier, the higher risk patients from Children's Hospital, the higher risk patients from our AYA program, and then those who are adult survivors. So 3 streams, but 1 adult survivorship program, which is characterized by a common population of adult survivors that we think, and there are data to suggest that they're really more alike by current age and their survivorship than different by their age at treatment at this point. This, we think, offers a lot of opportunities for clinical efficiency and resource sharing as well as research. And this is modeled, as I said, on our successful pilot experience at the other institution. Very briefly, because I know this is going to be addressed in the subsequent conversations, but our opportunities provided by the Affordable Care Act and healthcare reform. And the problem this is addressing, of course, is the dramatic under and uninsured state of patients who are in their early young adulthood. In this case, the Patient Protection and Affordable Care Act already has implemented a number of measures that will benefit these patients. A key one we've been hearing about is remaining on the parental policies until 26 years of age, although, as I've said, that in our setting where we have 70% Medicaid patients, it's not real helpful for us, just for a small section of our patient population. But coming in 2014 are some additional provisions that should be helpful for not only long-term survivors, but also early upfront care. So to close, I'd like to just summarize a few of what I think are key observations and recommendations that perhaps we can move forward with. If successful transition of survivorship care is affected and facilitated, or there are barriers from these 4 different levels, one recommendation would be that more funded research is needed to define and support transition readiness and competency, and that would affect the patient and family levels. Under the provider level, I would say that we need to introduce survivorship training or survivorship care, that whole concept, and some of the details of it in professional training, especially in the primary care fields. And in addition, increased our development of clinical support tools for primary care providers who are seeing these patients. And then finally, at the health system level, I would say that it would be helpful to have more funded research for the innovation and comparison of some of these transitional care models, moving toward a more seamless survivorship care network between the upfront treatment center and the providers who may be providing long-term care in the community, and then, of course, the holy grail of having continuous insurance coverage for the AYA population. And to address, again, in sort of a cross-cutting way, this serious problem of a follow-up gap in this population, I would say that the data that we saw earlier, where the follow-up with general medical care is actually not too bad, and it really falls off in comparison to the specialty center follow-up. I think this not only points up a problem with follow-up, but it points to a possible solution, which is increased utilization of primary care providers whenever possible for the long-term care. That's where these patients are, it's where they're going, and to the extent that we can use a tiered system to utilize that, it may be effective. And then finally, if these patients, if there's a certain residual population who will never come back, no matter how hard we try, if we can at least develop more effective methods to push key health education information out to them so that they're at least getting the benefit of that information, if not actually participating in long-term tracking formally, it's better than nothing at all. So thank you very much for your attention, and I'll look forward to taking questions at the end.